has the value-based care movement fully realized itself to date?
We saw that primary care practices that were in value-based payment programs, they were reporting that they were able to continue to provide care, right, through telehealth. They could pivot a little bit more easily to virtual care. Their dollar flows were different, right? I was talking about it's not just getting more for what you're doing, but the structure of that payment itself and those prospective cash flows mean you can keep the doors open. You saw less burnout. I think that's a huge thing that we should be measuring more and tapping into more. The burnout was lower among those practices relative to the ones that were running pure on fee for service. So to me, that's a really important sign and indicator that when these practices are getting the support that they need from these programs, it's helping.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
I'm joined by Purva Rawal. Welcome to the Analyzing Healthcare podcast by Scale Community. I appreciate you being here.
Thanks for the chance to chat with you today.
Looking forward to it. So Purva is the former Chief Strategy Officer at the CMS Innovation Center for both Medicare and Medicaid. We know CMS Innovation Center because of Liz Fowler, who we've interviewed a couple of times now, and the important role that CMMI has played over the years. And excited to get into some of your experience, Purva, and some of your thoughts on the state of affairs today in U.S. healthcare. Looking forward to it.
Sounds great. There's definitely not a dull moment in U.S. healthcare right now.
We've picked the right industry if we're looking for excitement, that is.
Yeah, and a full employment model. So, yeah.
Yeah, that's right. So you've spent a lot of time on value. Values are an anchor stone for you in your career. What goes through your head when I say the word value in healthcare? What are the first thoughts that come to mind?
Like hope and promise, right? That you can actually build a health system that orients itself around people. That's the work that I've been doing for the last 15 years in policy in DC, but it really dates back to my work even before that. I'm a clinical psychologist by training, and the work that I did back in the early 2000s when I was getting my PhD was I was doing a lot of health. I was trained as a health services researcher. And some of the early work we were doing in children's behavioral health at that time was really about using decision support tools and outcomes measurement to help states build systems of care on children and their needs. And so, and I keep, go back to that early experience, I think really shaped what I thought healthcare could and should look like in the US and other places as well, right? Like how do you, so when I think about value, I think about a system that is wrapped around people and what they need. So it makes me feel hopeful. I know that word value is really loaded though. So if you talk to, consumers and focus groups, and we did a lot of this when I was at the Innovation Center, you say the word value often to patients and consumers, and they think they're getting some kind of like budget deal on healthcare, right? It's not the top, the best care that they could be getting. There's something about it that's like discounted. And so I know that the word is loaded for many people outside the policy world, but to me, it's very, it holds promise.
You say it to a primary care group and they think you're talking about downside and upside risk.
Correct.
So it really does depend who you ask. I'm more in your camp. When I think of value-based care, I think of healthcare that stands the test of analysis, right? The right care at the right time for the right person, with the right reimbursement model, the right incentives that are all sustainable with the right outcomes, the kind of care that shines, that everyone can be proud of. So given that, where in this country, we'll start with this country, are we falling short and why? And I'm purposely asking you something very broad. So you could tell me Illinois, pediatrics. You could say hospital care across the entire country, and here's why. You could say commercial payers, employer self-insured care, whatever you don't like, almost maybe your top 5 biggest areas of concern where the gap is widest.
Yeah. All right. If I had to give you my top 5, and they're all probably, if I wasn't thinking on my feet, I would find a way to connect them all. So there's a thread probably through them, is my guess. But my top 5, number 1, you already said it, primary care, right? We know that having a strong primary care infrastructure is related, has all kinds of benefits for a health system, right? Lower spending, better mortality, lower rates of mortality, better population health, better for communities. That's a place where we are just falling short in the US, right? We know what the answers are. I mean, the evidence is there. I think there's a number of reasons. I think the one is the financing around primary care. It's a, fee-for-service payment system that undervalues that specialty. And the current fee schedules and payment rates don't account for all the work that primary care has to do. So I think number 1 is just the financing.
Before you get to number 2, I'm going to push you a little bit more. So does that manifest in a shortage of primary care physicians? They throw up their arms. There's just too much work, too much compliance, too much digital EMR upkeep, not enough reimbursement, and therefore I quit. So are we looking at a shortage?
I think it's probably both, right? And I haven't followed some of the workforce and pipeline issues quite as closely the last few years, but I've been doing work in the primary care space for over a decade, including with family physicians.
Here's another example. We went through this with Liz. Access to primary care. You've got a lot of states that can't be proud of the percentages of their residents, their state residents, who don't have a doctor, haven't seen a doctor.
Correct.
And in certain demographics, it's as high as 50%, particularly Hispanics. It's unbelievable.
Yeah. On the shortage issue, I think it's both. People are retiring, and we know that, and surveys are showing that. Number 2, residents don't want to go into primary care and family medicine. It doesn't pay well, especially when you're coming out with all this debt, and you're going to be overworked. So I think there is a definite, the financing structure influences who goes in and their ability to stay. And on the access issue, 100% agree. The numbers aren't great on the percentage of Americans that have a usual source of primary care. And I think the other piece is
especially,
knowledge.
By the way, as you head south.
Correct. And the knowledge, right, that people I don't think there's a great understanding that having access to a usual source of primary care is better for you, right? So, the telehealth and the urgent cares and the doc in a box, you can get an immediate need met, but it's not the longitudinal care that you need, right? It is like, that is one of those specialties where having a relation. Yeah. Correct. And having a relationship with a primary care team is, one of the goals that we had set out when I was at CMS, and, this whole idea of accountable care, i.e. having a longitudinal relationship between a primary care team and a person. And that to me is the essence, right? That's the foundation for a high performing health system.
Especially when even still today, we don't really carry our patient health wallets around with us. And so we already started a handicap in most places when it comes to questions like, how are you doing today relative to how you were 5 years ago?
Yeah.
What medicine are you taking today relative to the medicines that you took 5 years ago? What number surgery or treatment is this for you over the last 10 years? We don't really engage in longitudinal discussions across the board.
Correct.
I made this point before. We're all still walking around. I know that Epic introduced a MyCare solution. I think it's called MyCare, that is increasingly popular. I know that Epic is very popular amongst health systems, hospitals. So there is progress being made here, but I would still argue that the average citizen is not walking around with a patient health wallet that's easily accessible.
No, and there's pockets, right? So I personally am like a Kaiser Permanente patient and member. And that's a place that does longitudinal primary care, right? Like if I'm not every year getting all of my preventive care and preventive visits, I'm getting not only emails that I get on my app, I'm getting phone calls eventually, which I did. This year I missed a screening and my doctor told me I had to get it done and I forgot. And the nurse called. She's like, hey, you really have to get this done. So I'm accountable to like my doctor in some ways. My doctor is clearly, and the care team is clearly keeping an eye on what I need to be doing as well. That happens when you have a relationship, and there's and the infrastructure surrounding that primary care team is enabling that kind of outreach and work.
So value care is synonymous in both our minds with longitudinal care.
Mm-hmm.
Long-term, broad perspective care as opposed to episodic care. And I think that's a really important point. But let me be a devil's advocate. So primary care is underpaid. You're part of CMS. The team you're with is an A+ team. I'm getting to know a lot of them. They fixed so much during the tenure that you all shared. Drug pricing negotiated by Medicare, huge change. Why not just squeeze in a better reimbursement model for primary care physicians? You were there.
Yeah.
Why not just fix it?
Yeah, I think that's a fair question. I will say I think we made some good progress, and had we had longer, I think we would have been able to hopefully do more. I am hopeful though that the current administration, based on some of the recent work they've put out, are interested in strengthening primary care. And actually, some of what was done during the first Trump administration, they actually did try to change some of the fee schedule issues around primary care. They got pushback from Congress because of specialists. So there are political issues here. I think paying more for primary care is not necessarily a partisan issue. The question is the statutory constraints, right? There are constraints that Congress has written into the law that need to be addressed. And so it limits what the agency can do. And then there are the political considerations about, in essence, what are budget neutral payment environments. Right, where paying one specialty more means a bunch of others are going to get nicked, and that bothers them, right? So it just creates some bad dynamics.
Yeah, CPT codes, 20% increase, that comes out of something.
Correct.
Yeah, it's tough. It's tough going.
I will say some of the things we did do or tried to do. We had launched a new advanced primary care model for standalone practices, for federally qualified health centers, for independent primary care practices that we know are especially struggling. That actually, it was a net investment in primary care. And then we not only looked at those practices, but, obviously your listenership, your viewership is probably familiar with ACOs. I know you are, but we took some of these principles around like what do we do to strengthen primary care across the board? And we applied it across the portfolio. So when people think about CMMI, they think, oh, what's the next model? But oftentimes there's, what we were trying to do is create a more comprehensive strategy that you could apply. So we know primary care is an issue. It's not just a pocket here for independent practices. There are primary care practices, a number of them in ACOs, for instance, right? Or in these like state-based efforts. And so can we apply, our goal was to we were applying the same set of principles to strengthen primary care across the market. And so one was increase the investment in primary care and change the structure of the payment. So it's not just more dollars, but how are you getting the dollars, right? Instead of having to bill for every single service, because a lot of what you're doing isn't billable in a traditional sense, right? It's the non-face-to-face consultations. It's making sure somebody's seeing a social worker, connecting people to behavioral health. And so it's, creating capitated or more hybrid payment models where you're getting prospective cash flows to do that kind of work. And the second piece of the strategy wasn't just financing, but it's also thinking about disparities and how we are addressing disparities in access and outcomes. And you asked me originally, like, what are some of the kind of big challenges that continue to face U.S. healthcare? I think health disparities is a really big one. That would have been my number two. And then the third is alignment. And
Wait.
Yeah.
Too fast. We're gonna focus in on number two in a second.
Right.
You're racing ahead. All right. So finishing off on number one.
Yeah.
Last point / question that I would offer you or throw into the debate ring is, it does seem to me that ACA, Medicare Advantage, the Medicare Shared Savings Plan, the ACOs, that whole risk-based, performance-based, value-based paradigm shift, revolution, was partially built in order to actually reward the primary care class correctly and better. So my question is, and the funding was there and Medicare Advantage became enormous, 50% of all Medicare, or greater at this point. So adoption was wonderful. If you were to ask the average primary care physician today, 15 years from the adoption of ACA, is my life significantly better? What would the average primary care physician say and why? And is that arguably one of the most important points in addressing this question? Has the value-based care movement fully realized itself to date? And I know it's not a timestamp. It's not fair
I hear
just
you.
timestamp it. The evolution continues.
Yeah.
But just if we would just take a step back and ask the
two-part
question
answer.
today, how are we doing?
Yeah, two-part answer. I don't think your average primary care physician is going to say that things are better. I spent, and you probably got this impression from like we spent a ton of time when I worked for Liz at the Innovation Center speaking to people, doing speaking engagements, getting out there across the country and hearing from people. I did a lot of speaking to primary care physicians. And like I said, I did a lot of work prior to my time at the Innovation Center with family medicine and primary care in particular. And I don't think your average primary care doc would say that things have gotten better. I will say there are pockets of promise for those primary care practices that are in value-based payment models that are actually driving additional resources, infrastructure, and dollars to those practices. We have a couple of bright spots that tell us that, even if no, I don't think the value-based care movement in primary care has fully realized its potential. I hope not. I think we have a lot more that we can do and achieve. But a couple of bright spots that I would always ground myself in and continue to is number one, during COVID. We saw that primary care practices that were in value-based payment programs, they were reporting that they were able to continue to provide care, right, through telehealth. They could pivot a little bit more easily to virtual care. Their dollar flows were different, right? I was talking about it's not just getting more for what you're doing, but the structure of that payment itself and those prospective cash flows mean you can keep the doors open. You saw less burnout. I think that's a huge thing that we should be measuring more and tapping into more. The burnout was lower among those practices relative to the ones that were running pure on fee for service. So to me, that's a really important sign and indicator that when these practices are getting the support that they need from these programs, it's helping. And then I think as we were meeting with a lot of our model participants, oftentimes we would meet with primary care doctors who are participating in some of these models, and we did a number of site visits. And I remember a few very clearly where I asked primary care providers why they were part of this organization or this model, our ACO REACH model, for instance. Like, how is your life different now than before? And I'll give you one anecdote. One of them said, I used to see about 30 patients a day. I see 10, but the 10 that I see are sicker and they're more complex patients. And surrounding me now, it's not just me. I have a care coordinator, a social worker, and they are all keeping an eye on those 20 other patients that I used to have to keep an eye on. And they're telling me, hey, so-and-so just, had a change in medication. I wanted you to be aware of it. And they're happier and their doors are open and they are financially doing better. They're practicing at the top of their licenses and they're surrounded by a team. So that's just anecdotally, that's how it should be working. I think we're seeing pockets of that. And what we now need to be able to do is spread and scale that more systematically outside of just tests.
Yeah, I mean, it's a loaded question, a very flawed one, right? Happiness, it's this elusive thing. You could pay someone $500,000 to be a primary care physician 1 year. And if they make 450,000 the next year, they're miserable. But if they made 450 the next year and the prior year they made 400, they're thrilled. So it is a flawed question. Are you happy? Are you unhappy? But we do see consistently in certain fields transitions, inflection points that lead to more satisfaction. I'll give you an example of one. The movement to per diem or locum tenens in hospital staffing, especially ER rooms, has created more happiness for a lot of anesthesiologists and CRNAs who are enjoying premium wages because it's more expensive than the W-2s and more freedom when they're busy, which currently they seem to be very busy. There's a shortage in the marketplace. So you're sort of getting the best of both worlds. My pay went up and I might be really busy, but I'm busy on my terms. And I have less administration to deal with, not more. So those kinds of sudden inputs, I'm a cardiovascular surgeon and CPT codes went up by 30%. I'm doing the same number of procedures and I'm taking home more pay. And to my family, I'm a hero. Look at me with my extra pay. So those things are very well received in the marketplace. What's interesting about the primary care, value-based care movement is that it's difficult. It's just difficult. So when you get rid of all the administrative burden, all those additional intermediaries, which we're all sensitive to, how many administrators does it take to deliver care in America? And the truth about somewhat ugly truth, it's not, ugly may be the wrong word, but unfortunate truth about value-based care is that it's the right way to think about healthcare, coordinated care, risk profiling, moving away from pure volume incentives. It's all right. But the underlying to all of it is, wow, it requires a lot of infrastructure. a lot of spend, a lot of people, a lot of staff, a lot of data sharing. Otherwise, it all falls apart.
Mhm.
And it often has fallen apart where, the infrastructure fell short. So it's a tough one. All right. Number two, disparities. Talk to me about disparities. You also, Purva, you have an increasing interest in global healthcare and value overseas. So let's look at disparities from maybe a global perspective as well. How are we doing versus over there?
Yeah, I haven't looked directly at disparities here versus overseas, probably because we have a very heterogeneous population in the US. It's very unique. And the more that I learn about, um, on the face of it, it's obvious, but, most other countries are much more homogeneous than the United States is, and they're smaller. They tend to be smaller. The challenges we face here are unique in many ways. But in the work that I've been doing, what you're finding are some very common global health challenges, regardless of the size of countries and the diversity of those countries. So, for instance, obesity. I'm finding that's like, those are issues that people are facing in Asia, in the Middle East, in Latin America, in the U.S. Obviously, metabolic diseases, chronic diseases, diabetes, cardiovascular disease. It's everywhere. Aging populations everywhere, especially in Asia. I've also been hearing more and more about health related social needs and social drivers of health or non medical drivers of health. There's people are using all kinds of terms, right? But more and more health systems are cluing into the fact that, nutrition, housing, and transportation matter for meeting people's health needs. So those are, I think, it's interesting to me because there are some very common challenges. I think the way that they manifest in the US sometimes is unique, again, because of heterogeneity of the population. Every health system is complex. Every health system is complex. I don't care where you are. Our complexity is maybe next level along with some fragmentation. But, when you think about disparities, I think you had mentioned a little bit about primary care access disparities, but that's a good one, right? When we have access disparities in primary care, and we know what access to high quality primary care actually results in, some of the things that I talked about at the start, it's obviously, we're going to have downstream impacts, right, on things like cancer screenings and cancer outcomes and mortality and many things that are honestly avoidable. And so a lot of the work that we were doing at the Innovation Center across CMS was focused on disparities reduction. And I was lucky enough to lead some of that work for the last year and a half that I was there. And that's where, it really helped me start to connect the dots between really thinking about all of the different ways that value-based care and payment can be used to solve different problems in the health system. The more that I dug into it and the more that I learned and worked with our teams, you have this flexibility in the way that you can drive resources. And that means that you can drive resources in a way that gets at some of those drivers of health disparities.
So would an
Yeah.
example be not just educating, but investing in those patients that maybe struggled with care, but actually translated to significant spend, right? And
Yeah.
utilization. And by investing with economic incentive, here's a program that rewards a provider or provider group for keeping that patient base populace out of the ER room, out of the hospital, right? Through preventative
Yeah.
care, through continuous care. You're also addressing disparity and you're also addressing cost at the same time. Is that what you're describing?
Yeah, I think that's a really great way of putting it. One concrete way that we were doing that is that there are underlying reasons why there are access issues or these outcomes. And oftentimes, what you're seeing in a lot of underserved communities is underutilization of primary care and preventive care and all the things that you're talking about. So you're going to see an overutilization of like EDs, for instance, right? So some of the things that we were testing and I think are still in play in these programs are, for instance, payment adjustments based on factors that are indicative of underservedness. So you can use geographic indices, you can use whether or not somebody is like a dual eligible or they're getting a low income subsidy to identify lower income populations, or we know there is a correlation between, low income communities and health outcomes. And so you drive extra dollars in that direction. And so what you're starting to do is change the financing infrastructure. You're starting to increase access in those communities. And then it takes a little time to get to the outcomes that you're talking about, but that's the goal. First, you got to drive dollars in a different direction. And then you've got to start holding people accountable for a different set of outcomes once that infrastructure is built out. And that was, sort of that is the next step. Then you start saying, well, can I start using quality measures that are disparity sensitive, for instance, and start to see, are we closing some of those gaps? Eventually, maybe you get to a place where you're actually paying based on, disparities reduction or more equal care. So, yeah.
It's interesting. My audience, I throw myself in there as well. Our gravitational pull is towards reductive, fact-based reasoning, because that's just the human mind doing what it does. So what we really want from US healthcare is one or two inputs leading cause and effect to very definable outputs. And US healthcare is incredibly frustrating because that relationship is broken all the time. And so you end up throwing up your arms and saying nothing works, which is why the favorite headline that most journalists use for US healthcare is it's broken, still broken. And so I'll give you a perfect example. No matter what progress, Purva, your team might have made in creating more access to care, in closing some of those gaps, as you described them, the average citizen would point to the ever-growing cost of US healthcare and the ever-worsening outcomes. And no better way of describing outcomes than life expectancy. Nothing came of it, right? We're still dying way too young relative to the rest of the world. Life expectancy, 76, 77, 75 for men, 76, 77 for women, across the board, across the country. And so there are other metrics that we speak to when we think about healthcare. Our obesity rates have actually started to improve, but I think the average person in the US still rightly considers them outliers, certainly compared to most of our peer group countries. I think we have a communication problem where we almost need to sort of take a step back and start at the beginning with, well, this is how we're going to define success in our industry. And it's not, we're spending a lot and we get the worst outcomes, because that sort of keeps us estranged from all the progress that we make. So if I give you a microphone, literally, here's a microphone, and you had the attention of the entire country for 2 minutes, what would you point to in terms of metrics that speak to us closing gaps over the last 10, 15, 20 years? The good news.
The good news, yeah. I look at a lot of what happened after the Affordable Care Act, for instance, and we look at not just coverage rates going up significantly, and
An
we've
extra
covered
15
more
million
people.
covered.
Yeah, when you think about what was happening in this country in 2008 with nearly 50 million people uninsured.
It's all we spoke about.
It's
I mean,
right,
that was
right.
the story,
Yeah.
50 million uninsured.
And then fast forward 10, 15 years later, and you look at the number of people and is the coverage perfect? No, but they have actual health insurance with standards, right? They have a standard set of benefits. And then you start to look at some of the, I think pulling this out of the races in my head, but the Medicaid coverage data and what Medicaid expansion is associated with. Right, it's not all causative, but the correlations are pretty good and the data are pretty good that as we started expanding coverage to low-income adults through Medicaid, we're seeing families in less financial distress. They are financially more secure. Peer-reviewed academic studies have shown this to us. We see improvements in mortality, screenings, preventive screenings, the use of preventive services. So that to me is the real story of incremental progress. When we think about how much healthcare cost 15 years ago, it's not that our costs are going down, but at least we're starting to ask a different set of questions. And heck, we know a lot more now about how we want to try to pay for things, right? Value is it's just woven into the entire landscape. When I was working on the ACA with Liz and others in 2010, people barely knew what ACOs were outside of DC and a few other pockets, right, of places where they've been trying these things. But this is part of the landscape and the lexicon, and this idea that, it has actually had measurable impacts on the way post-acute care is utilized, for instance, in the country, right? We've seen delivery systems and healthcare delivery realign around many of these ideas, even if we haven't achieved like the end goal. So to me, like those are just, a couple of examples of how the world looks really different today than it did 15 years ago. And we've got good data and evidence. And the last thing I'll say on the spending issue, and I think there are obviously some academic studies on this, and then there was some of this actually made the news as well. But when the Congressional Budget Office was projecting Medicare spending back in 2010, we are way short of where those spending projections were going to be. There's a number of reasons, right? You've talked to Christy, you've talked to Mina. I mean, there's probably like, drug pricing
By the way,
issues
the
like
math
rolled into
is
there's value.
the maths is unavoidable because two of our healthcare segments have continued to spiral out of control. One of them, I think you just got a handle on, and that's drugs. But hospitals and drugs during that same period, last 10 to 15 years, annual inflation 5 to 15%. But the rest of healthcare has way lagged the country's aggregate inflation rate, lower than 3%. Outpatient care, 0 to 1% inflation during that period of time. That's where most
It's
doctors
amazing.
make their money.
Yeah.
And so, by the way, there's been a massive wave of outpatient care. So the volume has been monumental and the cost has been non-inflationary.
Right.
So yeah, Medicare is saving money somewhere. It's
Yeah.
not just
And you can't say this model and this, like you said, that's what frustrates everybody. I can't say I pushed this button and I got this outcome because it's just not that's not how things work in the real world. We're not doing controlled experiments here. But clearly something's happened, and is value the answer and responsible for all of it? No, but I find it hard to believe that it's not responsible for some of it.
okay. And these inflation rates are very important because most people don't think about it, but when they hear Medicare going bankrupt, they don't appreciate that most of Medicare is paid for by annual income as a tax. And so it really should only go up in spending at a rate that's equivalent with the annual increase in income. It will eventually run out of money if that rate of increase exceeds the rate of growth in income. But as long as they're in parallel with each other, Medicare should be fine. Again, every year the Medicare is going bankrupt forecast year changes, right? It
Yes.
never used to be 2035. It was 2025. Then it was 2015. Also, another interesting little anecdote. Okay,
Yeah, and
so
go
yeah.
ahead. No, I was just going to say then, and that's sort of the role of Congress and the executive branch and CMS, right? Is to say, look, what does that projected bankrupt date look like, and how are we managing the program so that we don't have an imbalance between the funds coming in and going out?
There seems to be, it's a US condition that I get the right to point out because I'm not entirely American. There seems to be
I couldn't tell.
yeah, raised in England, but there seems to be a US precondition to apply a constant or permanent state of panic when it comes to healthcare. And I'm not sure it's a global phenomenon. In America, there seems to be a permanent state of friction and volatility. And I can't exactly put my finger on it. I think it's because half the industry is for profit and half the industry is not. And I think that's going to create friction. It's almost political divide right down the middle. Get rid of all the money makers. They're ruining everything. And then with state and federal funded healthcare, you always have that we can't really pay for all of this reality. We have budget neutral constraints and there's going to be shortages. So it's almost like a perfect microcosm of all that works and all that doesn't work in both sectors, public and private, for profit, non-profit. And so it's interesting. We're never quite satisfied and we never feel like we've quite solved it here in the US.
Yeah, I guess that's a good thing too, though, because it means you're always looking for solutions, right? But as you were saying that, it reminded me of when
But it's schizophrenic. You agree with me? It is
yes.
completely schizophrenic.
Yeah, the last few months of my being off and just doing a little more project-based work has been actually, I feel like my blood pressure has gone down.
What
But as you were
what does the average CMS executive staff member think about the for-profit partner that you have here in the US? The good, the bad, and the ugly.
I think I've learned to never speak for anybody else. I've been trained to do that, working in this city for 20
Get
years.
your
But
training.
no, I mean, to me, I think there always has to be a healthy balance. When you look at other, it's not like any system, most systems are not either purely public or purely private, right? Even if you look at, European or other single payer systems, there are still aspects of private industry in those systems. I think it's a balance between the core pieces of the system that are for the public good and then being able to weave in, inject, leverage private sector innovation to be able to come up with new solutions, to come up with technological advancements, therapeutic advancements. care delivery advancements. In the US, it's probably a bit imbalanced. I will say, as you were talking about the public and private, it also reminded me of when I was teaching. I taught undergrads, and I taught a class called The Politics of Healthcare, which like basically teaches itself because there's, healthcare in America is so political that you sort of read the news and talk about it, and there's the class. But the first thing I used to say to the students is like, I don't even, when we think about healthcare in America, there's this idea that there's the public and the private, and then there's the for-profit and the nonprofit, and the two are, that there's a bright line between the two. And I said, I'm not even going to use those terms like in this class, because healthcare is, it's gray, right? When you're talking about private plans, many of them are, for instance, Medicaid MCOs or Medicare Advantage plans, and they get public dollars. Even if you have employer-sponsored insurance, there's a tax subsidy. Those are public dollars, right? And if you're talking about public health care, technically, Medicare Advantage is run by private plans. So there's this whole, it's all gray.
Yeah,
And maybe it's grayer here than other places, but yeah.
If you add Medicare and Medicaid combined, the average healthcare provider thinks of the government as either their largest customer or their second largest customer, with rare exception, right? And so it is gray. There's lots of gray. Question for you. Looking forward, next 5 to 10, maybe even 20 years, I'll leave it up to you to decide. The federal government, state governments interacting with a changing healthcare landscape. We're automating everything. Everything's going robots. There's no more obesity. It's all GLP-1. We've run out of money. We have a federal budget gap that is insurmountable and enormous federal debts. We've got all these different headwinds, tailwinds. What does CMS look like 5, 10, 15 years from now? What's changed? And what do you hope will change but won't? So your best forecast.
As you were describing this futuristic world, have you ever read The Road by Cormac McCarthy?
No, but I'm going to make a note of it. I
sort of like
write down my book.
It's very dark. It's very depressing. Okay. I think it was made into a movie, and there was like no way I was ever going to watch it.
Is it about technology, AI?
No, it's sort of this post-apocalyptic world, which is like a little like that. You were kind of describing the healthcare version of that in my mind.
I'm being extreme for a reason. Like let's assume. I mean, you can push back and say, look, Roy, nothing's going to move that quickly for us in any direction. It's going to mostly feel the same. That would be an answer. Or you could tell me, look, it's going to be incomparable, unrecognizable to what it is today, and here's why and how. I'm just curious to see what your forecast looks like.
I mean, I think there's a real I guess my hope would be that CMS and the healthcare industry is really able to harness what is, I think, a sea change in technology in a way, and I hope we can embrace it in a way that solves for the core problems in the system. So for instance, like, everyone's talking, the AI is going to be bigger than the internet revolution. And, I think healthcare is a little bit behind on that. I think the government's been a little bit behind, but I think using it has to be coupled with a vision, right? How do you want to harness the new technology to make healthcare simpler for people, to make it less expensive, to increase access? You can use and harness, and then you can, once you've put that vision out there and those goals out there, then you could be developing those technologies and putting them to use for the greater good. So that would be my hope, that, that we embrace those technologies, not just to, increase profit or figure out how to deny care, but to really get to the goals that you outlined initially, right?
I think we might be short an AI regulation or sort of constitution, like a whole regulatory body of work surrounding healthcare AI, the do's and don'ts. I know of some healthcare AI regulations that are out there. We can't present an AI agent in the delivery of care, in providing consultation of care. We have to remain within the bounds of what's human. The difference between AI,
you can't do, right? That's telling what you can't do. You can also put a positive sort of policy vision out there.
Yeah.
And then the technology should be developed to achieve that positive policy vision. And I'm not an AI expert. Like, since I've left, it's something I'm learning more about. I don't think you can function in our world today without learning more, and especially in healthcare. So something I'm trying to get smarter on.
I've seen a lot of AI diagnostics, right? Smarter, better, faster, cheaper imaging. That's common use. A lot of AI clinical research, right? Smarter, better, faster. A lot of AI peripheral work in the clinical setting. So transcribing or scribing. I've seen some co-pilot AI tools that augment how a clinician goes about providing care. But I think I've also seen a very clear red line between augmenting and improving and substituting.
Yeah.
So there are I don't know of any AI nurses that are out there providing care, let alone AI physicians. And I think there's a hard red line around that. What's interesting is how long will that red line last? But how many case studies? It reminds me of self-driving cars, which have been before Waymo, right? The experimentation has been going on for 20 years. And only now, 20 years later, are we seeing adoption, public sphere adoption with regulatory support.
Yeah.
And it might take that long. And I don't appreciate that we might still be talking about AI substitution in healthcare coming any day now in 2045.
Well, you can have me back on in 2045 and hopefully I'll know more than I do now.
But you see what I'm saying, right?
No, I hear you. And I don't know how fast
days.
it'll happen, but it's going to happen. And the smarter the smarter we all get as an industry and the agency gets, the better I think it is for the system and for people. But then you also asked what I hope doesn't change. And what I hope doesn't change are the integrity of the institutions themselves and the cultivation of the expertise that resides within CMS and those institutions. Because I will tell you, having spent almost like 3.5, 4 years there, some of the smartest people I have ever worked with. And it still takes people with experience and dedication who are motivated by civil service to get the job done. And so those are the things that I don't, right? The topics change, the challenges change, but what is the foundation are the people that are doing the work, empowering the work. Those are the things that I hope don't change,
That has been coming across, I have to tell you, meeting so many of your colleagues, incredibly talented and dedicated. What a special place. Last question for you, and most controversial of all.
I thought that was a good note to end on.
No, not at all. We're
right,
still going to go through it. But this is not intentionally last. It's a topic that I've just been thinking about the last couple of days. COVID response. From a CMS perspective, what was it like? What did you see? What did you learn? And what does CMS do differently next time we go through a pandemic, a crisis of that nature?
I started in August of 2021. So when I came in, I think at that point, people that wanted to be vaccinated had been vaccinated. We were remote. I didn't meet many of my colleagues for months in person until we were able to come back in person. But people were reeling. People worked so much and so hard at that agency. You could feel it. They were tired, and then you had new administration come in with all kinds of energy and everyone's gearing back up. I think what COVID response also just, hearing from my colleagues that were in the thick of it in 2020, especially, they were able to move mountains in a way that I don't think anyone would ever anticipate the federal government could. But again, you had you had a staffed up civil service to do the work. I think it also, COVID was terrible. I don't think we fully still grasp like what it's, the imprint that it's left on the world. In our healthcare system. But what it also did, I think, was free up our thinking around when and how care should be delivered. And some of those things we've been able to carry over. So I think it became it not only demonstrated that you have federal agencies and people that can move fast in crisis response when they are enabled to do so and have the data and the backing to do so. But number two, that it can also be a real time for learning. And you get used to doing things the way that you've always been doing them. But then you start to get things like hospital at home. And you realize you can waive this regulation and waive that regulation. Right. And it's not compromising quality. It's actually reducing administrative burden. It's helping people get care where they want. Those are things that we can continue, and those should be learnings that we carry forward.
Are those the big lessons that CMS carries with it today? So all of a sudden, an elevated position for home care, for virtual care, and maybe an elevated recognition of the savings that are available through creating interruptions to what is just habit.
Yeah.
Right. I'm going to the hospital because I always go to the hospital. All of a sudden, I'm forced to stop for a year or two, and COVID is long gone, and I'm still not going to the hospital because my behavior has changed. So that's an opportunity in savings, right? Excess care utilization just born of habit. But I'm also on the negative side of the ledger. I worry that too much care was defined as elective and non-essential. This term,
Yeah.
remember non-essential? I felt like 98% of all society fell into the category of non-essential.
Non-essential. Yeah.
And I was worried at the time that the weighting was a little too skewed and
Yeah.
that, cardiac arrest. And I know the president at the time kept using behavioral health and depression and suicide, but there's thousands of other examples. There's oncology, right? There's
Mhm.
preventative diagnostics.
Yeah,
There's
absolutely.
so many
Yeah,
unintended consequences of interrupting essential
I
care
agree.
by falsely defining it as
Yeah.
non-essential.
I think we also saw that outside of
Too
healthcare, like
simplistic would
yeah,
be my critique.
yeah.
And I'm sure I would have been just as hurried and rushed to just focus in on the crisis at hand. But
I would hope that those would be some of the lessons, God forbid, if
yeah,
there is to be another pandemic. But I will tell you, I think on the negative side of the ledger too, I'm concerned that the systems, the people, and the data are not in place in a way
they're
that they
not.
were in 2020. They are
They're
not.
not. And so
And
many of the
so
lessons learned are
right?
not
So
being
hence my
spoken about.
qualifiers, you can get a good crisis response. You can get some good learnings. Now, can you apply them the next go around? I don't know
I feel like
because of the
we've
current
entered
environment.
global cognitive dissonance. My sentiment and it's just one person's view. I feel like we all struggled so much with it that it's almost like, let me use a metaphor that works. Anyway, we don't want to think about it. And I'll give you a perfect critical lesson. It's one of 100 that we should be talking about regularly. What happens to labor in a crisis? This was a shock to everyone.
Yeah.
That labor vanishes and the little labor that's left is 4 times more expensive, right? And the system has to somehow absorb that.
Mm-hmm.
So that whole connection between crisis and inflation, I think we've put it all in the hands of too much government Keynesian stimulus from old Joe Biden. For Joe Biden, against Joe Biden, irrelevant. That's not where most of the inflation came from. Most of the inflation came from, and I know this because we were there, nurses that used to cost $80,000 a year now all costing $200,000 a year and refusing to work for $150,000. And so that was symptomatic. It was everywhere. Truck drivers, grocery store workers, you name it. Inflation everywhere and a massive shortage of labor. And I'm not saying that that's the wrong thing, the bad thing. I'm just saying that no one talks about it. Like that's there waiting for us in the next crisis. All the workers will vanish on you. And now what are you supposed to do?
Yeah.
So it's just, are we spending enough time preparing for the next crisis? I think universally, probably all think the answer to that is no.
No,
We just don't want to go there.
yeah.
We just don't want to spend time on it. We want to
Well, I
pretend it
also
never
think
happened.
we have taken down the infrastructure that would allow us to maybe
That
respond
too.
or even to anticipate it, right? When I think about the CDC, I think about ARC, I think about all of the HHS agencies that play a role in monitoring, surveillance, response, and that's just at HHS. So, there's so many, like you're getting to the point of like you're even talking about secondary issues. My mind was going to some of like the first order issues of like, are we going to know? Are we all going to, are we
We
going
won't
to?
even know we're in a pandemic. There'll be no one there to report it. This came up, I interviewed Carl from the CEO of the World Health Summit. This was 2 weeks ago. And he said, we're living in an age of distrust and we're expected to build, invest, improve in a paradigm of distrust. And those two things don't really mesh. So we're not building and we're not investing because we distrust. The
Right.
truth is, half of that distrust, I'm sure, is well earned. Half of it is not. So where do you draw the line? When do you start to earn the trust that is earned and get the institutions the support that they need? When does that happen? So those questions remain. Purva, I'm so grateful for your time today. I learned a lot and really appreciate it and hope to be able to do it again with you soon.
Yeah, I would really enjoy that. Thanks for having me.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.